hospital and was working with me for a while. He did his fellowship at Manipal Hospital and then another one at Gangaram Hospital, and then joined as a consultant in the hospital. And now he's moved to Christian Medical College, Ludhiana, where he's the assistant professor and in charge of Division of Pediatric Endocrinology over there. So good evening, Dr. Ayush, and welcome back to your old hospital again. And
thank you, ma'am. Thank you, ma'am. And it gives me a great pleasure to welcome ma'am, Dr. Archana Dyalarya, who doesn't need any introduction. She is the pioneer of pediatric endocrinology, so as to say, in Delhi. And she is the senior consultant as well as chief of Division of Pediatric Endocrinology and Diabetes at Institute of Child Health, Sir Gangaram Hospital, New Delhi, and I had a privilege of working and trained under her for a very long time. And I also welcome the presenter for today's session, that is Dr. Nisha Basin, who is a DNB trainer, a wonderful person, so as to say, in Department of Pediatrics at Institute of Child Health, Sir Gangaram Hospital, New Delhi. I welcome Nisha and I hand over to you to continue with today's presentation.
Thank you, sir. Good evening, everyone. I would now like to start with my presentation. I will be presenting the case of IJ, 13-year-old female in Delhi. The informant was the mother and the history was reliable. The child was admitted on 13th of September and was examined by me on 18th of September. The child came with the chief complaints of increased thirst for 3 weeks, weight loss for 3 weeks, and fever for 3 days. The child was apparently well 3 weeks prior to presentation when she developed increased thirst, which was gradual in onset, associated with increased urination, and history of weight loss, which was approximately 5 to 6 kgs over the last 3 weeks. This was followed by the complaint of fever, which had been present since 7 days. It was acute in onset. Intermittent spikes were present. Maximum recorded was 103 degrees. It was associated with chills and rigors and was relieved by medication. There was no history of vomiting, pain abdomen or loose motions. No history of any increased water intake or decreased appetite, burning, maturation or discoloration of urine, cough or breathing difficulty, headache, trauma, and blurring of vision. In the past history, there was a history of white lesions in the mouth 4 weeks back, which had been treated with antifungals. There's no history of similar complaints in the past, no history of hospital admission. There is no history of any drug intake or tuberculosis. In family history, the mother suffers from type 2 diabetes mellitus and has been on regular medication since 2 years. The father is hypertensive on regular medication since 5 years. The brother has been diagnosed with dyslipidemia, but is currently on no medication. There is no history of any thyroid disorder or celiac disease in the family. This is the pedigree chart of the family, which shows 3 generations. The birth history, the antenatal period was supervised and the child was appropriate for gestational age. It was otherwise uneventful. The immunization history is appropriate for age. The child currently studies in 8th grade and is doing well in school. She has not yet attained menarche, but breast development started 2 years back. Mother attained menarche at the age of 12 years. By dietary history, both by 24-hour recall method, for both calories and protein, there was a deficit in calories by 9% and a deficit in proteins by 6%. To summarize, we have a 13-year-old female child who has been immunized appropriate for age, presenting with history of increased urination, thirst, and weight loss since 3 weeks, followed by fever for 7 days and history of oral fungal infection. So should I move on to the examination?
So does anyone have any questions at this point in the history? You can write your questions in the question box, or you go ahead with the examination. Meanwhile, people can put their questions. Ayush, would you like to ask any question at this point?
Nisha, what will be your differential diagnosis based on the history you have taken?
Sir, our differential diagnosis for this would initially be diabetes mellitus, because the child is presenting with history of increased thirst, increased urination, as well as weight loss. We will also have to rule out other causes like diabetes insipidus and primary polydipsia. We will also have to rule out other causes of osmotic diuresis, if there was any increased salt intake or any cause that could have caused acute kidney injury, which later on might have led to polyuria. So all of that, sir, with a negative history, we had ruled out. So if vomiting, pain, abdomen, loose motions, any dehydrating factor which might have increased thirst, any increased water intake that might to rule out psychogenic polydipsia, decreased appetite because any eating disorder which might be causing weight loss, any burning, maturation, discoloration of urine, which could also increase the increased frequency of urine, which might also be causing increased thirst. Any cough, breathing difficulty was mainly for any fever, to rule out any fever, any associated features with fever, and headache, trauma, blurring of vision, because in diabetes insipidus, we might have any central diabetes insipidus, might have any hypothalamic or pituitary cause, which might present to us with headache, trauma, or blurring of vision, and trauma, which in itself can later on lead to diabetes insipidus.
So what is the
Yes.
evidence against or for DI over here, diabetes insipidus, since you mentioned that?
Ma'am, there we will not have, our main thing would be, there would be increased urination would be present out there, but there are no associated features of that. Like increased thirst is more likely, and weight loss is more likely with diabetes mellitus rather than diabetes insipidus. Plus diabetes insipidus, if we are ruling out central, other associated features might also be present along with it, ma'am. Like
Right, you will have polyuria and polydipsia, but this kind of weight loss will not be
there.
Yeah, that's a lot of weight loss, 5-6 kgs in a short period of time. Do we have any other questions anywhere? No. Okay.
No, ma'am.
Let's go ahead with the examination then, huh?
On general examination, the child is conscious, cooperative, oriented in time, place, and person. The vitals of pulse was 98 beats per minute, regular. There was no radio femoral delay. There were and radio-radial synchrony was present. It was normal in character and volume. The respiratory rate was 24 cycles per minute. The afebrile on examination was 99% on room air. The child's hydration was fair, and the blood pressure was 110/60, measured in the upper limb. This is the anthropometry. As we can see that the weight for age for this child at the current weight was around between 25th to 50th centile, and the height was also between 25th to 50th centile. The weight at the time of admission was around 43 kgs. So it came under underweight category, but we had to consider the fact that 5 to 6 kgs had been lost over 3 to 4 weeks. So when we took her in, weight gain pre-illness, weight that was present pre-illness, that came above the overweight category. On head-to-toe examination, pallor was present. There was present a pigmentation on the neck folds, suggestive of acanthosis nigricans. The breast development was Tanner stage 3. Pubic hair was stage 3. Axillary hair was present. No signs of dehydration, icterus, cyanosis, edema, clubbing, or lymphadenopathy were seen. We had done per abdomen, our CNS, as well as respiratory system examination. So there are no positive findings that were present on per abdomen examination. As well as in CNS, the child was oriented, time, place, and person, was following all commands, and our examination for cranial nerves, motor, sensory, as well as the reflexes were normal. There were no signs of any encephalopathy. On respiratory system examination as well, there were no positive findings. In CVS examination, S1 and S2 was present, and no murmur was heard. So to summarize, we have a 13-year-old female child immunized appropriate for age that has presented to us with a history of increased urination, thirst, weight loss since 3 weeks, followed by fever for 7 days with acanthosis nigricans. The current BMI was 18.1 kg per meter square, and pre-illness was 20.8. So pre-illness, as we had seen from the chart, was above overweight, and the one which we have seen currently was under normal category with Tanner stage 3.
So what's your diagnosis at this point?
At this point, ma'am,
Did it change anything?
No, ma'am, it goes more towards diabetes mellitus, but we will have to see, first of all, what kind it was, and we hadn't done any investigative workup to see if there was any other underlying cause for it.
But on examination, what could it be? Type 1, type 2, some other?
The examination findings are going more towards type 2 because she has acanthosis nigricans present. She has, as well as her BMI pre-illness was overweight. She has family history with mother already suffering from type 2 diabetes mellitus. Her brother has history of dyslipidemia. It is going more towards type 2. However, polyuria and polydipsia in children sometimes could present more with type 1. And
so you're right that the child is overweight, so we definitely have to think of type 2. But the biggest problem these days for any kind of diabetes is that a lot of children are obese today. So even if an obese child develops type 1 diabetes, sometimes we think of type 2. So it is definitely a part of the differential diagnosis. But nowadays, weight alone is not the indicator, unfortunately. At one time, you would think of an obese child would be maybe type 2. And type 2s can also be symptomatic, but then type 2 diabetes, children with type 2 could be asymptomatic for a long time, and they may get picked up just on regular screening. I just want you to show that growth chart once again to all the postgraduates, the one with the BMI on the one behind before this. Yeah, so I just want you to make a note of this little quick tool up here, which is the BMI chart, which is there on all the IAP charts now. So one should have the latest ones. And if you plot the height and weight over here, you'll know immediately whether the child is overweight, obese, or below the 50th percentile. So in this, you do not have to calculate the BMI. It saves a lot of time, and it's right there on the chart. So you can plot quickly to see what the status of the child's BMI is.
I just want to add that if you're on this quick tool chart, if your BMI, it is not exactly BMI, it just gives a guide whether the child is overweight, obese, or underweight. If the child falls in any of the category, it is essential that you calculate the BMI and plot it on BMI chart.
Any other questions?
No questions.
Okay, go ahead if there aren't any.
The child presented to us in the emergency. The random blood sugar on examination on that day was 436 milligram per dl. The urine ketones were 3+, and the VEG that was done showed a pH of 7.3 with a bicarbonate level of 18. The child was started on IV fluids maintenance, which is normal saline. And her airway, breathing, and circulation were normal on examination. And the decision was made to admit her into ward and do further investigative work about why she was presenting with such symptoms as well as for fever. So on day 1 of admission itself, her hemoglobin was 13.9. Her TLC counts were raised, which were around 25,000. And her SGOT was mildly raised to around 60. Her urine routine microscopy showed that acetone was present along with 2 RBCs, but no pus cells were seen. HbA1c was 13.9, C-peptide was 1.3, IgA was 565, and TPGA, the result of which came out later, was negative. We did a thyroid profile, and which showed a value of 0.9, 0.8, and 1.03 for T3, T4, and TSH respectively. The CRP was 39. Her lipid profile showed that the cholesterol was mildly raised at 214, with the HDL value at 53 and LDL at 127, along with VLDL at 49, and triglycerides were 244. We had also sent her GAD antibodies, which came out to be negative, and the rest of the antibody screen that had been sent, the results are still awaited for it. So after the initial test, a diagnosis had been made that the child was suffering from mild DKA and had to be started on insulin when she initially came. So to calculate this insulin dose, we took a starting value of 0.7. So for pre-pubertal, we usually take it from 0.7 to 1 and pubertal from 1 to 2, but we start on 0.7 and then gradually increase. So for this child, since the weight is 43.3, we multiply this by 0.7, which is 30 international units. This gives us the total daily dose. So out of this total daily dose, 30% would be basal insulin. which we will be discussing later in our discussion about what is basal and what is the bolus insulins that are given. But for treatment, we give 30% as basal, and then boluses have to be given pre-meal depending upon the blood glucose. So with 30% of 30 units came out to be 10 international units, and this was given as degludec, which is injection Tresiba, which is a long-acting insulin. Then pre-meal RVS monitoring was done based on a sliding scale. So there is something called an insulin sensitivity factor, which tells us the amount of insulin that is needed to decrease our glucose levels. So 1 unit of insulin will decrease how much glucose. The formula is 1800 by total daily dose, but in pubertal children, we take it as 1500 by total daily dose, which came out to be 1500 divided by 30, so 50. So then we approximate 80 to 120, which is our range. And since we had already divided our remaining 20 units as 677, we will now go back to that. So it will be 7 international units for 80 to 120, which would be our target. And then we will increase one dose for every other range beyond that. The child was then monitored in ward after starting this insulin regimen for her to see how she was maintaining her glucose. And then titrating of the doses was done, and the dose was gradually increased to 12 international units, at which she was able to maintain her blood glucose levels. Adequate patient counseling was done about how to apply the insulin, as well as dietary counseling, and the child was planned to discharge with advice to follow up. So to summarize, this was a newly diagnosed case of diabetes mellitus. However, there were certain points favoring whether this was type 1 or which was the fact that the child had presented to us with mild ketosis. There were history of weight loss and increased thirst present, even though GAD was negative, but our antibody panel was awaited, which might suggest the child had type 1. Whereas the features that were in favor of type 2 were history of overweight, as well as the family history was present. There was presence of acanthosis, and C-peptide levels on examination, investigations were normal. So we have started the child on insulin, but the decision for further treatment has yet to be made.
And what other thing which on like in your history also favors type 2 diabetes in this case? Most of the things you have summarized, but one more thing points towards that it may be type 2 diabetes.
So family history was there, and
so you have started the child on a lower insulin dose. Usually at presentation, the requirement is on a higher side. So if that is there, that also points towards type 2 diabetes.
Any other questions? I think there's something in the box.
Yes, ma'am. The question is how insulin sensitivity factor is helpful in deciding.
You want to go back and show? Yeah.
So, ma'am, with what insulin sensitivity factor tells us is that how much amount of insulin, 1 unit of insulin, how much glucose will be decreased with that. So if along with this insulin sensitivity factor, if we were able to decide that within a range of 50, we needed this much amount of insulin. However, if we require a greater total daily dose, that means our sensitivity, like we will require a greater dose of insulin for each of that range. So it will help us titrating the dose.
Yeah. So basically what Nimisha is saying is initially we calculate the total daily dose. We gave 30% as basal because this was degludec. If you're using an insulin like glargine, you may use up to 40% basal also. And the rest of the 70% was divided into 3 doses to be given before the 3 major meals: breakfast, lunch, and dinner. Now this factor, it means that this calculation shows 50, which means that every 1 unit of insulin will bring down the blood glucose by 50 milligram per deciliter. So say if the child normally, we made this chart so because patients can't calculate it, but say if your pre-meal blood glucose is 200, so ideally it should be 150. So you are correcting for what you're eating, but you also have to correct for that 50, which is extra there. So if you add 1 unit, it'll cover up, it'll bring down that 200 also, plus it'll cover the meal that you're going to eat. So I think we have to do these things on a little regularly to understand clearly, but that is what she's saying. But usually what happens is, for a newly diagnosed patient to understand all this in great details is very hard. So it's easier to just make a chart, and then based on that, assuming that the diet and lifestyle are consistent, we can just increase or decrease, and then gradually we teach them other things regarding the diet, the carb intake, etc., which is, I guess, too detailed for for today's presentation. So that's how it is done usually. Any other questions, Dr. Ayush, or there's nothing in the box, I think?
No, nothing is there. You can continue, Nisha.
Yeah, go ahead, Nisha.
So now, ma'am, now we'll be moving on to the discussion to how to approach a child with diabetes mellitus. So diabetes mellitus is a complex metabolic disorder characterized by chronic hyperglycemia resulting from either defects in insulin secretion, insulin action, or both. Diabetes in children and adolescents typically presents as polyuria, polydipsia, nocturia, and weight loss, which are the features that we saw in our case. According to the ISPAC 2022 guidelines, type 1 diabetes is characterized by the destruction of beta cells, which is usually an autoimmune process resulting in loss of endogenous insulin production. Type 2 diabetes is characterized by the lack of an adequate insulin response in the presence of increasing insulin resistance. Monogenic diabetes is an autosomal dominant diabetes pattern, first term MODY, which may make up 1 to 6% of autoantibody negative individuals who may initially be considered either to have a type 1 or type 2 diabetes with decreased insulin secretion. So this is the chart in Nelson, which classifies diabetes. So broadly speaking, we have type 1, which we've already discussed, is when there is beta cell destruction. So we will have complete insulin deficiency. We have type 2, in which there's insulin resistance. So other specific type, we have monogenic diabetes. These can be of two types: MODY, which is maturity onset diabetes of the young, which will have all the chromosomal defects. We have neonatal diabetes, which could be pathogenic variants leading to transient neonatal diabetes, and pathogenic variants which lead to permanent neonatal diabetes. Then we have other mitochondrial disorders which are also associated with diabetes, such as Pearson syndrome, Wolfram, Kern-Sayers syndrome. Then we have genetic defects of insulin action itself. These are type A insulin resistance and other types. We have other genetic disorders which are associated with diabetes. These are Down syndrome, Turner's and Klinefelter's. We have other autoimmune disorders associated with diabetes, like Alpix, stiff person, and anti-insulin receptor antibody syndromes. We have drug or chemical induced. These are important because we have a large number of children who are undergoing treatment. So these could be children who are undergoing steroid treatment, are taking cyclosporin, sirolimus, asparaginase, beta blockers, Vapor, phenytoin, nicotinic acid, and pentamidine. We have disease of exocrine pancreas, cystic fibrosis, trauma, pancreatitis, hemochromatosis, infections such as congenital rubella and cytomegalovirus, and hemolytic uremic syndrome. Endocrinopathies that are associated with diabetes include Cushing, acromegaly, pheochromocytomas, and then we have gestational diabetes. So the criteria to diagnose diabetes mellitus is classic symptoms of diabetes are present, or there's hypoglycemic crisis with plasma glucose concentration greater than 200 milligram per dm, or you have a fasting plasma glucose greater than 126 milligram per dm, with the fasting being present as as defined as no calorie intake for at least 8 hours. 2 hours post-load glucose, which is commonly called as an oral glucose tolerance test, showing a level of more than 200 milligram per dl. And for OGTT, we need to give 75 grams of anhydrous glucose that is dissolved in water, or 1.75 gram per kg of body weight, to a maximum of 75 grams, or HbA1c more than 6.5%. However, if there is the absence of unequivocal hyperglycemia, the diagnosis of diabetes will require 2 abnormal tests from the same sample or in 2 separate test samples. And a value of less than 6.5% does not exclude diabetes diagnosed using glucose test. And the role of HbA1c alone as a diagnostic criteria for type 1 diabetes in children is unclear.
So I have 2 questions for you here, Nimisha.
Yes.
First is that role of HbA1c alone in the HbA1c, a normal HbA1c doesn't mean that the child doesn't have diabetes. So if you're suspecting you have a child who has, polyuria, similar situation, polydipsia, weight loss, etc., and your A1C is normal, it's not in the diabetic range, what would your next step be? What else could you do?
Ma'am, we could go in for an oral glucose tolerance test. We can do an
That's one thing. And what else? What if it's a thalassemic? I'm giving you a hint.
Basically, ma'am, the reason why we don't use HbA1c in children is because they have a lot of hemolytic anemias, which in itself, the hemoglobin becomes the confounding factor. Sickle cell anemias, thalassemics, and in which HbF could be raised, giving us the wrong value for this. So we should.
So what would you do there?
Look at their anemia profile also, ma'am.
Okay, so there's a test called fructosamine, which does not depend on the HbA1c. So usually we do that. It's an average of the last 2 weeks. So if your HbA1c is an average of the last 3 months, although the maximum reflection is from the last 1 month. So if you do a fructosamine, you will know if the blood sugar has been high in the last 2 weeks, and also if the child has some hemoglobinopathy. I mean, those things will take time to get those reports. I have another question for you. We did C-peptide to see whether it's type 1 or type 2. Why not insulin? Why C-peptide?
Ma'am, because initially in type 1 diabetes, when we start treating the patient goes into a honeymoon phase where the body starts secreting.
No, I'm talking at diagnosis. We did a C-peptide. Why not an insulin level? Why C-peptide is my question. After all, insulin levels are usually higher, right, in type 2. So why do we use C-peptide instead?
And C-peptide is basically the part of the insulin that is getting produced. So that is a subpart of the insulin. So that will tell us about the production, how much insulin is getting produced.
So C-peptide, insulin comes from there, and insulin is a very unreliable test. That's the answer. It's not a very accurate test. That's one thing. So C-peptide is a far better test. And the second thing is, the reason why I asked this question was a lot of people do the insulin test when the child has been started on treatment. And once you've injected the child with insulin, obviously the insulin levels will be normal when you send them to the lab. And then I have parents coming to me, children who are on treatment, the parents will go read somewhere or somebody will tell them do an insulin level. They'll do the insulin levels and come back and say, this child doesn't have type 1. How come the child is making so much insulin? So don't make that mistake. If the child is on treatment, has received insulin, insulin has absolutely no value at that point of time. It can just create confusion if you're not aware when the sample was taken. Dr. Ayush, anything?
No, ma'am. The only thing is that HbA1c is not done in children because the standardization has not been done yet. It is not because of the increased incidence of hemoglobinopathy. It can be there in adulthood also, but it is because the standardization is not there. A lot of racial differentiations are there, so that's why.
Hemoglobinopathy was for fructosamine, not for
HbA1c.
not for that. Yeah, not for HbA1c. HbA1c definitely alone, I would never take it, to be honest, although they have included it in the current definition. But we see children with A1Cs of 6.5 with a perfectly normal GTT without hemoglobinopathies also. So that is like Dr. Ayush said. But the hemoglobinopathies was to do with with a falsely raised A1C over there.
And also because a lot of labs have cropped up, so sometimes a single HbA1c value can be erroneous also. So if you feel that on examination and clinical history the symptoms are not matching, it is always better to repeat it from another lab, along with again fasting blood sugar and an OGTT.
Any questions? No. Okay.
Ma'am, somebody has raised the hand. I'll just.
Okay, just see.
Manchala is there, ma'am, but I don't think so they will be able to speak. Can you just
they
put
can't
the
speak,
question?
so yeah, you'll have to write the question.
Yes, I request you to write the question and we will be happy to answer it.
So should we wait for the question or?
You can move ahead. If the question comes, I'll ask.
Okay, so the differentiation between type 1 diabetes, type 2, monogenic and other forms have important implications both for the treatment as well as patient education. So there are certain diagnostic tools which can help us confirming the type of diabetes the child is suffering from. We have diabetes-associated autoantibodies, which are seen in type 1 diabetes mellitus. These include glutamic acid decarboxylase 65 autoantibodies, the tyrosine phosphatase like insulinoma antigen 2, insulin autoantibodies, and beta cell specific zinc transporter 8 autoantibodies. And the presence of one or more of these antibodies confirms the diagnosis of type 1 diabetes in children. The possibility of other types of diabetes should be considered if negative diabetes associated autoantibodies are present. There's an autosomal dominant family history of diabetes, which goes towards MODY. If the age was less than 12 months, and especially in the first 6 months of life, which goes towards neonatal diabetes mellitus. If there's only a mild fasting hyperglycemia around 100 to 150, especially if young, non-obese and asymptomatic. If there was a prolonged honeymoon period lasting for greater than 1 year, or an unusually low requirements for insulin, that is less than 0.5 units per kg per day after 1 year of diabetes. If there are other associated conditions such as deafness, optic atrophy, or syndromic features which might suggest a mitochondrial disorder, if there is a known history of exposure to drugs which are toxic to beta cells, such as immunosuppressive drugs, tacrolimus, cyclosporin, glucocorticoids, or some antidepressants. For management, we have insulin therapy, glucose monitoring, a nutritive therapy for the child, physical activity, as well as counseling. These children require follow-up with a specialist along with screening for complications. We will now be moving on to the insulin therapy. So as discussed earlier, the most commonly that is used is the basal bolus regimen, where multiple daily injections of rapid acting and ultra rapid acting are given, along with longer acting as basal. So there are multiple ways where this can be given to the child. We have insulin syringes, pens, and pumps. So insulin syringes, we have U100 and U40. So there's an image later on. So here, as we can see, there is 100 units are present per ml, and then we have 40 units that are present per ml. This is usually present for regular insulin as well as NPH. Then we have insulin pen, which have one unit increment is present, and now we have even 0.5 units of increment that are present. We have insulin pumps, which are a newer system which deliver short-acting or regular insulin using a battery-operated pump over 24 hours, and this will give us a basal continuous supply, and rapid acting will have to be given pre-meal. So the bolus dose will continue. What are the injection sites where these can be given? The most common ones are abdomen, where 2 finger space from the umbilicus we have to give, lateral aspect of the arm, front of thigh or lateral thigh, and lateral upper quadrant of the buttock. So regular insulin, rapid acting, and NPH are more readily absorbed from abdomen and deltoid region as compared to thighs and buttocks, whereas the long-acting insulin does not show any change in absorption levels, irrespective of the site where it has been injected at.
So Nisha, 1 second. Insulin pumps you said will give basal, and for bolus also the same insulin is used. You don't have separate bolus. You put a short-acting insulin. It could be a rapid-acting insulin. Mostly we don't use regular very often, though it can be used, and it provides the basal continuous supply. Plus the bolus is also with the same insulin. So there's only one insulin that is used for both, and the pump delivers both. And the new automated pumps are also there now, which are linked to the sensor. But of course, that's another discussion altogether. All right, go ahead.
Insulin doses are based on pre-meal glucose levels, the meal composition, particularly the amount and type of carbohydrates, and the expected physical activity in the coming hours. So prandial insulin, which is the rapid acting and ultra rapid acting ones, and intermediate acting, which we usually give, which is 55 to 70% of total daily dose, and basal or long acting one, which is once or twice daily, which is around 30 to 45% of the daily dose. So as ma'am had discussed earlier, 30% was for Reglutic and 45% was for glargine. Now these are the different types of insulin. We have ultra rapid acting, which is faster aspart, and rapid acting insulin such as aspart, glurylacine, and lispro. So lispro can be used in all ages, whereas Aspart has been approved for ages above 2 years, if I'm not wrong now. And ululacine is for above 6 years. And the onset of action is between from 15 to 30 minutes, and the peak action occurs within 1 to 3 hours, and the duration remains for 3 to 5 hours. Regular acting is around half an hour to 1 hour onset of action. Peak action will occur within 2 to 4 hours, and the duration remains for around 5 to 8 hours. Similarly, for neutral protamine hegudron, onset is within 2 to 4 hours. Peak will occur by 4 to 12, and duration of action is 12 to 24 hours. And that is it. Patients who are getting NPH will require it to be given twice a day. Dosing will be present, whereas basal long-acting ones only require once a day dosing, like glargine and degludec. The benefit of degludec is that it doesn't have any peaking action, and the duration of action remains for greater than 42 hours. So this is, as we can see, determined glargine and degludec, they do not have any peaking, which is seen with the rapid acting insulins. So the target blood glucose that we aim for is that for fasting, we aim for a 90 to 130 milligram per day. And if it is greater than 150 or 90, we consider a child to have poor control. Postprandial, we aim for 140 to 160, and the average bedtime should be around 110 to 150. A poor control would be considered if it is greater than 180 postprandial or at average bedtime, or less than 110 averaging at bedtime. So continuous glucose monitoring is a device that is, you place a sensor over the skin to measure the glucose level in the interstitial fluid at frequent intervals. The readings from the sensor can be read as real time or as records, and will show us the fluctuations that have happened over a certain period of time. These usually last by 5 to 14 days and may need calibration with finger prick values. It helps us to calculate the time in range, which is defined as the percentage of time when the blood glucose was maintained between 70 to 180 milligram per dl, and the optimum value was 70% or more. Now, the dietary counseling, you have to limit the intake of snacks, sweeteners, and food which have high glycemic index. So 1/3 of the food should be high fiber rich carbohydrates. 1/3 is fruits and vegetables, and 1/3 is proteins. This was according to the IAP guidelines, whereas the ISPAT guidelines tell us that carbohydrate should be around 40 to 50% of the energy intake. Moderate sucrose intake should be present. Fat is around 30 to 40%, and less than 10% should be saturated fat and trans fatty acids, and protein is 15 to 25%. The reason it's important to know about the fat content is because what happens is when anybody moves from a carbohydrate source, it ends up taking a lot of sources which are rich in fat. So we have to make sure that the saturated fat content is less than 10%. The fiber recommendations are usually for children greater than 2 years. We calculate as H in years plus 5, which will be equal to grams of fiber that are needed per day. Exercise, we recommend the child to have 60 minutes of moderate to vigorous aerobic activity daily, and bone strengthening exercise at least 3 days per week. However, we need to take care that exercising and playing in children is a risk of hypoglycemia. So frequent RBS monitoring should be done, especially before and after exercise. They should be aware about the symptoms of hypoglycemia, and we have to modify the insulin schedule around their exercising periods. And they have fast acting carbohydrates in case hypoglycemia does. Sick day guidelines, these have to be taught to parents after diagnosis and reviewed annually. So anytime a child has any illness, we have to monitor their insulin as well as glucose levels. Glucose have to be monitored 1 to 2 hours. We have to maintain the hydration with adequate salt. You have to check for ketonuria as well as ketonemia. We have ketone strips that are available, and blood ketone levels have to be checked. At no point do we stop insulin. We will have dose modification, which I will be discussing later. And in case there is any underlying cause which the parents are not able to handle at home, they should immediately be advised to come to the nearest emergency. So for total daily dose calculation, since we have already counseled the parents for ketone strips and checking for urine ketones, if the urine ketones are moderate and the blood ketone levels around 0.6 to 1.5 millimole, along with blood glucose between 180 to 400, then you increase the total daily dose by 10 to 15%. If the ketones are large with increased amount of blood ketones more than 3, you increase the extra insulin by 20%. However, if the blood glucose itself is above 400 and the ketones are moderate, then 15 to 20% of total daily dose increase. And if their ketones are large, then 20% of the total daily dose. If the blood glucose is less than 80, then regular insulin should be omitted. Frequent feeds in small quantities should be given with 2 to 3 hourly blood glucose monitoring. Basal insulin should be given. However, if urine ketones are positive, basal insulin can be reduced by 30%. There are certain complications. We have microvascular and macrovascular complications. We have microvascular, which are diabetic retinopathy, nephropathy, neuropathy, and macrovascular complications like dyslipidemia, hypertension, and ischemic heart disease. So for microvascular complications, if the child is suffering from any type 1 diabetes mellitus, and it has been 2 to 5 years since the diagnosis, or the child has turned 11 years old, whichever occurs earlier, or has attained, whichever occurs earlier, we will start screening for microvascular complications. If the child is suffering from type 2 diabetes mellitus, then all of these have to be screened at diagnosis itself. Sir, are there any questions?
Yeah, one question is there that body mass index or body roundness index, which one of the following, both of them is more sensitive?
Sir, I'm not sure. I'm not sure about the answer, sir. I've only read about body mass index.
So body roundness index is a newer index which has come, not very new. It has been there for last 8-9 years. Because in BMI only 2 parameters are taken. One is your height and then the other is weight. So there are a lot of limitations to that it is not able to differentiate between the lean body mass and the visceral fat. And the visceral fat is the one which increases the risk of cardiometabolic diseases. On the other hand, theoretically, it is said that body roundness index, it takes into the account your waist ratio, hip ratio, and then also height. And then with a mathematical formula, it calculates an index. And theoretically, they say that it is more representative of visceral fat rather than the lean body mass. But the issue in the children is that it has not been validated. And in very young children, it has been said that the limitation being that it is not superior or inferior to that of body mass index. And also it is difficult to calculate. Therefore, as of now, body mass index is the one which is has been studied. And for body roundness index, a lot of more studies have to come and comparison have to be made so as to see whether it is more sensitive or not.
I think in children, BMI is the gold standard. And yes, for visceral fat, waist circumference is a good indicator. And we do have Indian percentiles also. So those are the two main things that one should be familiar with. And you were right about ASPAT. You were saying, I think 6 years you said, na? So that's one year. No, that's a little old, the ASPAT guideline. It's 1 year for that. And FIASP is 2 years.
Yes, okay, sir.
Approval age I'm talking about. Very nice presentation. Yeah.
That's the end of it. Thank you.
Yeah. It's going to be hard for my kid to have type 2 diabetes. He's used to being number 1. Yeah. They're the ones who get type 2 because they're studying, sitting and studying all the time. So not so hard, huh? Nice cartoon. Any questions from the audience, or Dr. Ayush, would you like to comment?
A very good presentation. The only thing is that it is very difficult to differentiate between type 1 and type 2, especially in adolescent period. And as Madam said, and as also as you have seen with this case, that it takes a lot of clinical judgment so as to make a final diagnosis. But whatever said and done, the initial management will be insulin therapy, whether it is type 1 or type 2 diabetes in this adolescent period. If you are not sure about
and with DKA, you have to start with insulin and then take a call, see the clinical progression. And also initially, even type 1s, they go into remission. So sometimes it gets very confusing even for us, whether they're in remission or do they have type 2. So you just have to wait it out and see. Remission is unlikely to last for very long. But we've had children in the past, I think Dr. Ayush and me, where we were quite sure it may be type 2, they were antibody negative, but ultimately they did have to get back. They had a very good and a very prolonged remission. So it's very variable, and it's best to watch them closely and not be in a rush. I know parents keep pushing the doctors that insulin band kar do, but you should do what is right and best for the patient.
And also because of availability of this genetic testing, lot of kids who were previously diagnosed at either type 2 or type 1 are now being diagnosed to have MODY. So for that also you need to have a lot of clinical suspicion. Though you have given a guidelines, but still we have found that sometimes even if they don't fit into the criteria, just based on the clinical suspicion, they turn out to be MODY.
There's also a MODY calculator which can be downloaded, and you put the information and it gives you the, I don't know how accurate it is. I used to use it earlier, but now with these, with the genetic, with the NGS having become more reasonable and easily available, I think it's easier for us to check whenever we are in doubt as far as possible. I think there's another question, Dr. Ayush, maybe?
Yes, ma'am. The question is, mild DK patients who are fully conscious, cooperative, accepting orally well, vitals are stable, should we give them IV fluid management as per mild DK, 5% dehydration or not?
Mild DK, what the guidelines say, sir, is that if the child is accepting oral fluids well, then we do not need to start with IV fluid management. Is maintaining the circulation, peripheries are warm, pulses are good volume, orally is accepting good fluids. We can straight away start the child on subcutaneous insulin and OPT basis also. That is not the indication for admission. But in our child, such a child already had fever, and all of these complaints, once we started asking about fever, they told us. So hence we admitted the child, but only if in moderate and severe, in which we have signs of dehydration that are coming and oral intake is poor, we start with a dehydration correction.
So I just wanted to add that all the children who have mild, moderate or severe DK will have some dehydration component. That's why with mild DK also we tend to have 5% dehydration because they do have polyuria. As you have said correctly, that if it is mild DK and child is stable, you can directly start them on subcutaneous insulin. But it is very, very important to correct this dehydration. This dehydration can be corrected either with IV fluids or orally, but you have to be very particular about it that the dehydration is corrected over 48 hours. So dehydration has to be corrected. It can be oral, like you said, on OPD basis. You have to tell them to drink more water, take more electrolytes, and but it has to be corrected. So next question is, I think, for Archana ma'am, they have just written reversal of diabetes. Ma'am, do you want to add to it?
I wish that was true is all that I can say. There's nothing known as reversal of diabetes. There is remission, yes. And or sometimes, if a patient has been diagnosed with, has type 2 and is being treated as type 1, and then you realize has a different type of diabetes and they, can get off insulin, then people will label it as reversal. There are some studies with verapamil where if you have just been diagnosed with type 1 diabetes recently, they have done studies with it to delay the further, attrition of the beta cells. It kind of is prolonging the remission phase. For how long, I don't know. And I mean, these are relatively new studies, and routine use of these drugs is really not recommended. And the other one, I think, is teplozumab, which is approved for children who are antibody positive and have impaired GTT. So they actually don't have diabetes, and these children are picked up when you're screening families and all. And teplozumab has been approved in the US by the FDA for this stage, but once you are diagnosed, then there is a study with verapamil, but I think they need to be reproduced. There were some side effects, so we should not just use it blindly till we have a little more data on that. And reversal of diabetes comes from usually swamis and sadhus, I think, most of the time, if that's what you're talking about. But yeah.
And he has another the same question. He has written that that there is a lot of advertising on the social media about reversal of diabetes, and I want to just say that because they are just taking advantage of poor parents who are willing to do anything to stop insulin, whether it is correct or not. And also the honeymoon phase, which happens immediately after your diagnosis, complicates the thing, and they tend to land up in severe decay if not on regular monitoring.
There's another question there.
Yes. The other question is for poor patients who do not have refrigerators, keeping insulin in pots containing water to help, or that insulin efficacy is less due to suboptimal temperature. What to counsel? Nimisha, you want to please?
So if the insulin has been opened and is on room temperature, it can be used for around 7 to 8 days, I think so. And if it is being kept at a temperature 4 to 8 degrees Celsius, then it can be stored for 3 months. And if, as they said, there's a poor patient, then there's a clay pot method, which is a double clay pot method, where you have an outer container of clay filled with water, and then you have an inner container in which you store the insulin. So that's the double clay pot method for storing insulin in poor settings. But even on room temperature, they say it stays for at least I think so 1 to 2 weeks is what I had read, and in a room in refrigerators at 4 to 8 for 3 months. So double clay pot is what we use.
So you're talking about unopened. Once you start using your insulin, then most of them, even the pens, etc., cartridges have to be discarded in 4 weeks. Degludec is the only one which is good for 2 months as per the company information. And I think the longer the once it's opened, the insulin, depends on the temperature. It could vary from place to place, but yes, that age-old putting it in the matka when you don't have a refrigerator, I think that's what is practiced in the periphery. Would you like to say anything, Dr. Ayush?
Yes. So the only thing I want to say that on room temperature in India, because we live in a country where summers are very hot and winters are very cold. So this increased variability kept on room temperature might cause loss of efficacy, so as to say, because what you are telling is a room temperature which is there in the Western world. Okay, they don't have very hot summers or very cold, like they do have cold winters, but not very hot summers. So another thing is that that matka thing is very, very good. The only thing is that during rainy seasons, because of high humidity, that time the efficacy may be low, because they work on a principle in which water is being continuously evaporating, which causing cooling inside that matka. So if humidity or relative humidity is high, at that time it can become less efficacy. But other than that, it is quite efficacy. Olden time, people used to drink water from matkas, and it was pretty cool, so as to say.
So there's another question, I think.
Ma'am, another question is self-monitor without having glucometer, like polyuria, polydipsia, or urine color. So I'm not sure what.
Yeah. So I think maybe you're talking about the glucose strips, the urine strips, maybe. If
So
that's what it is, then we don't
how
only
to monitor without glucometer. That is what.
CGMS.
So I think that was the olden time when because glucometers were very costly or not available. That time you used to use that urine strips to see whether glycosuria is there or not. But that is very unreliable, because your sugars have to be more than 180 for that to come in the urine. And also hypoglycemias can't be monitored if you are using that urine ketodiastics for monitoring. And also, if you don't have glucometer, you can go for the newer ones like continuous glucose monitoring, if you want to cut down on tricks, where you can put a patch and then continuously it will help you monitor the sugars over next 14 days.
But in some of the villages, they still use the urine strips where they're not able to afford that. In fact, I remember, I mean, I don't see that now, but earlier when I had started, we would ask them to even cut the strips into two so they could use it twice. But remember that urine has been sitting there for a while, and when the child actually pees and you check it, it could reflect a blood glucose, which was maybe an hour ago or 2 hours ago, depends on how long he's been holding on. So it's very unreliable, but maybe better than doing nothing in that scenario but I think most people can, and the government also gives a lot of free things. So I think most people do manage to get a glucometer in today's times, I would think at least.
Yeah, so glucometer, like if you go for Jan Aushadhi centers, the glucometers which are available are very, very cheap. And the strip cost is also very less. The strip cost is nearly 5 rupees per strip. And if you can afford, you can go in for branded, commercially available glucometers also. And they are also quite reasonable, so as to say.
Just to teach patients not to even have urine strips. Yeah, right. We don't want them to keep them. But only thing is our keto diastics, which we ask them to keep to check ketones, that also does it, but we never tell them to look at it. So they may keep the strips for that, but otherwise, no. No, we
I think he wants to know that
now patients don't even ask about it anymore, actually. I think it's so outdated, this technique, but yeah, I guess maybe in smaller towns, that's still the case.
I think he just wants to ask that whether we can monitor type 1 diabetes without checking the blood sugar just based on the symptoms and urine color. That is, I think, the primary question.
Not in today's times. Not a good idea. Any other questions?
And I think we have answered all. Just to summarize, as ma'am said, that without like checking for the blood glucose, we can't have a good control. So just based on the symptoms and the urine color, you can't manage a child with type 1 diabetes. For that, you have to check the blood sugars at least 3 times a day so as to have a very good control and prevent future complications. We don't have any other questions.
Okay, then we can close the session. Thank you, Nimisha. Very good presentation. Well done. And thank you, Dr. Ayush, for joining us and contributing so much to the session today. And thank you, everyone, for attending the case discussion today.
Thank you, ma'am. Thank you.
Thank you, ma'am.